sometimes, usually in clinical setting, you will never see in the hospital whoever tests the smell. Nobody.
Yeah.
You just ask the patient. Now, is your smell okay? Okay, then this first nerve is finished, done. So usually we do this kind of screening. You said that smell got problem, only then we test. So if no, we don't do it. So usually we don't do it. If you do it, you have to close one nose. You have to give a smell to test, so that patients should close the eyes so that they'll see what kind of things you are testing. That's very simple. So you just test each nose whether it's okay or not. Okay, the optic, the second nerve. Yeah, you must know what you are going to test, right? The first is the visual fields, and your fundoscopy, right? And pupil reflexes. There are 4 things there. Right? The pupil is a little bit tricky. Only the efferent pathway is from the optic nerve. The efferent pathway which responds is from oculomotor, third nerve. So you test for the efferent pupillary defect or not, right? That's about it. So visions, visual fields, your fundoscopy. Fundoscopy, of course, usually we don't do unless you have some big problem, really problem, then we look into the fundoscopy. And you haven't gone to your eye posting yet, right? Done. Okay, then if you are asked to do it, the eye may have this kind of section, but in neurological examination, usually you don't need to do that. Because ophthalmoscopy and your 6 minutes may not be free. Even fundoscopy not finished one. So the visions, if you have the discharge, you can test the visions. You can ask them to read. So when you ask to read, you have to cover your eye. So if you have time, you have just an eye examination, you have to go detail. If no eye examination, you just test one level, one letter only. And this is what? You just read what I point. J, D, F. So it's all can see, right? So the other eye. So it's okay. So meaning that it's eye vision both sides. Okay, right? So sometimes you don't have the charts and all that. You just ask him to see the letter far away from where. What's the letter there? What is this? And near one, just ask some people to read. Can you read this letter? Then it's near vision, far vision is already settled, right? So if you have this chart, you can do that. So the visions, the visual fields. Then if you don't have instrument, don't worry. You can use your finger. So when you test the visual fields, you have to sit face to face, and then your eyes to focus to your eyes. So now you cover your eye. So no. The same. So this eye, if you look at my eye, so this instruction should be fully given. So your hand, when you move either pin or your hand, should be midway between you and the patient. You cannot do that. If you do that, you can't see. Patient can see. So you're not comparing your field with the patient field. If you do like that, patient can't see. You see, then you see that patient have a visual field defect. So it must be midway between you and the patient, so that both can see. So because you are comparing your visions with. So when you start to see that, you say yes. You just look at. So you test the temporal field vision. See, then you test the nasal field visions. Yes. So these are very quick screening. If you want to do slowly, you can use the pen and do when you see the red pen. The other is the other eyes. Okay, when you see. Okay. Yes. Okay. Yes. Yes. Okay, so we test both eyes, the temporal vision, the nasal vision, upper and lower. So all 4 quadrants is tested. So this is test the visual fields. So then your pupil. So you have a torch light. Okay, so when you test the pupil, so the one. Or is it? Oh.
No big. Oh, no, no.
So when you test the eye, you should be darkened, so never mind. So you test the eye, the light should not go to the other eye. So now you look at this eye, the direct reflex, you will see the pupil constrict. Then you show the same light and you look at the other pupil. So then this is an indirect consensual reflex. So if you put that, it should be constant. If both are intact, this eye doesn't have problem. Then you test the other eye, the pupil. Then this is a direct reflex. Okay. Then you look at the other eyes and show the same thing. You look at the other eye, same thing.
Yes.
If you have both eyes got direct and consensual, the other side also got direct and consensual, this pupil is all intact. So because when you show it, the efferent pathway is from this eye. If this efferent pathway is affected, let's say third nerve is an efferent, then this efferent pathway is affected, the pupil, the efferent pathway is not stimulated, so the pupil will not constrict at all. So both pupil will dilate. Let's say this eye got problem, efferent pathway problem. Then if you show, if you look at the direct also no, consensual also no, you see that. But if you test the other eye, what happens is that this eye is efferent intact. So that in this eye only efferent is affected, efferent still intact. So
it will
when
constrict.
you show this eye, what happens?
Both will constrict, yes.
Then direct also constrict, indirect, consensual also active. So this eye doesn't have one. This eye have a efferent problem. But to make sure you can do a swinging light test.
Yes.
So what else? You put the affected eye, both eye will dilate. You swing the other eye, both eye will constrict. Then you swing this eye back, then both eye will dilate. So this is called swinging light to confirm this the efferent pupillary defect. Okay, very simple. Now, this is not with explanation. So you see that it take time. But if I do it very fast, you can fit it within 2 or 3 minutes, 2 minutes kind of thing. See, first the optic nerve kind of thing, maybe 1 or 2 minutes. So just okay. If you time it, I will ask. You close your right eye. Can you read this? The other eye, what about the other eye? Can you see that? Okay, what color is it? What color is it? With the other eyes, what color is it? So if you don't have a color, you see how I check, you get just a red green discoloration. It's the most common color blindness. If you see color, it's quite common. Okay, now you look at my eyes, you cover your eye and just look at my eyes only. When you start to see my hand wriggling in, say yes, 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 yes. Okay, cover the other eye. Yes, 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 yes. Okay, now I check the pupil. So how many minutes I take?
Less than 1 minute.
You see, this is how if you know, if you do gradually within 1 minute you finish it. This is the core sequence of examination, right? You should be practicing it again and again. So now I go for first, second, third, fourth, sixth. Third, fourth, sixth together we combine.
Yes.
So third nerve stand and pupillary reflex. We already tested actually there. So if you are only asked to do third, fourth, sixth nerve, then you have to do pupillary again. If all cranial nerve already done. So the only thing, the third, fourth, sixth nerve, there's no sensory component, only motor, so that you have eye movement only. So you follow my finger, don't move your head. So test on each test only. Okay, you see one or two? One or two? One. One or two? One or two? One. So this is the full 6 examination. Less than 1 minute, right? So, but you must know the interpretations. Why I ask those questions is that when you look the eye, you must know that when patient look into that, you are testing the 6th nerve here and the 3rd nerve here. If up here, both eyes 3rd nerve. If you go down here, you are testing this eye 3rd nerve and this eye 4th nerve. You must know that. So if patient see double vision here, either this 3rd nerve or this 4th nerve, and then you see the eye movement, whether this is abduct or not. If this abduct doesn't go down well, this is the fold up problem. If this eye doesn't go down well and see double image, it is not this fold up, this is third nerve. If you see double visions here, this eye do not abduct, does not abduct means that this sixth nerve region. If this eye doesn't abduct means that this is a third nerve of the other. Right, so this is both third nerve. So you either you have left or right side only, you have to differentiate. So again, the same thing. If you go here, this is sixth nerve, this is third nerve. Both third nerve, then it's called third nerve, fourth nerve. So this is a few interpretation about that. Then the fifth nerve have got the sensory and motor. You must remember that sensory and motor. So you have examined the sensory. The fifth one got the three divisions, right? The ophthalmic, your mesentery, and mandibular. So when you test it, you can use the cotton wool. If you don't have a cotton wool, you can use your finger. So, but use a cotton wool. And sometimes you need to do both touch and pain, but one is enough. One is enough. Okay. Can you feel this touch? So you have to touch either, because you are going to test the face. You better go to the sternum. Can you feel this touch? Okay. Can you close your eye? When you feel it, you say yes. 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 The same. Yes. 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 The same. Yes. Same. So you have to remember that the mandibular is in front of this angle of the jaw. After the angle of the jaw, it's not mandibular nerve anymore. So the place you touch is very, very important. The second division of the maxillary region is the frontal. So you have to left and right. You always have to ask whether they feel equals or not. Okay. So then if you want to do, you can do a pain sensations all over the complete one. But if you ask a number of nerves to do, then you can skip that one, right? So this is about. Then you go to the motor. Motor include the master of mastications. The master of mastication. So you just have to clench your teeth, So you feel the muscles. You put the temporalis, your masseter muscle. Then you open your mouth. This is a pterygoid. So resist. Need to resist. Okay, you see that. Can you move your jaw left, right? So this is pterygoid. You examine, and then you can do a jaw jab. Jaw jab usually we don't ask you to do. Once you have a sensory motor intact, we don't do that. Don't do. Some grudge in the blood. Corneal reflex also. We can do corneal reflex because it's in the ophthalmic divisions. So this reflex and jaw jab we don't do. It's very uncomfortable for the patients. But unless you feel this not feeling, no sensory means that you have to do a corneal kind of or you have some kind of jaw, some sensory or problem, muscle a little bit weak, then you have to do a jaw jab. Right. So if normal, then you can skip that. Okay. This is about fifth nerve, right? The sixth nerve already included, so we put for seventh nerve. Seventh nerve also, usually seventh nerve is a motor. The sensory is only anterior part of the tongue. So the taste we don't do it in a practical scenario. Only in some neurological clinic, specialized clinic, they will test. They were interested in which branch of facial nerve is affected and all that they will test. So usually we don't. So we just test for the muscle of your facial expressions. Can you raise your eyebrow and see whether it's symmetry or not? Okay. Can you pop up the cheek? Okay. Then you resist my pressure. Okay. Okay. Don't let me push. So the purpose of doing that is patient with paresis cannot puff the cheek. They will go up. So you know that it's a paresis. But patient have some weakness, not really paresis one. There's some weakness only, then probably he can do puffing. But when you press it, it cannot resist. It will go up. Right? So this is called weakness, partial weakness. Then close your eyes. So patient may be able to close the eyes because the weakness is not very strong. But there's a mild weakness, then you have to do against the resistance. Okay, don't let me open it. Okay, can't open. But if there's a weakness, you can open the eyes. Right, so you have a weakness and true, very obviously paresis and my weakness, you can differentiate by this doing that. Okay, then you show me your teeth. Okay, can you whistle? Okay, this is okay. So these are all facial muscle expressions. So these are just the sequence of examination. That's it. But the interpretation is upper and lower motor neural lesions. So upper motor neural lesions will have only the lower side of the face. But the lower motor will have even the front, the whole gone. So just this is the interpretation. Okay. Then the eighth nerve, you have a vestibulocochlear, and there are two components there. I'll tell you a quick test and your one. See, when you test the hearing, if hearing is intact, you don't need to do Weber and Rini test. Because Weber and Rini test is just to differentiate conductive deafness from sensory neural deafness. So if the hearing is okay, you don't even need to do that. So to test the hearing, there are two types. You have to go back from the patients. Okay. Close one ear and you whisper, or you just make a sound. Can you hear the sound? Repeat after me what I said. So other people can hear. So if he can hear both sides and he can repeat your what you have said whisper, his hearing is intact. So if one side do not clear, then you have to do Weber and Rini, whether this is truly one or not. This is screening, right? So, but for Weber and Rini, okay, Weber and Rini, the Rini test is that there are two ways to test. One is the finding, normal finding is air condition is better than bone conduction. So this will be louder than this one. So what you do is you check this one. Is louder here or is here? The first one. Which one? The first one. So this is the one that because your air conduction is better than the bone conduction. When the bone conduction stops, the ear still can hear. There's another way to do that. What you do is that when you stop hearing, just let me know. Okay. Can you still hear that? Huh? Oh no. What you expect? No, I don't. No, when you start not hearing it, just let me know. Okay. When it just stop not hearing anymore. Now? Yeah, so so the easier way, the swiftest way is you compare this and this straight way. So this is the Rini test. So the Weber is more simpler. So I will put the things on your forehead so that where you hear equally or not. Just okay. So this is the Rini and Weber test. Okay. So the Rini test positive is normal. Remember, Rini test positive is normal. So negative is not good. There will be, so you all know that interpretation, right? If you have a sensory neural deafness, you have a. So the Rini test will be
positive. No.
No, the sensory neural is not conductive.
Positive.
Sensory neural doesn't will be, Rini will be normal.
Yeah, positive.
Rini will be normal. When you do a Weber test, it will be reduced on the affected side.
Yeah.
So if you have a conductive deafness, then you have the bone conduction, or the bone conduction will be better than your ear conduction. Then you do a Weber test, it will be louder on that side. Right. So this is the interpretation of that. So this is the cochlear functions. We have a vestibulocochlear nerve, right? How are you going to test the vestibular function? Not gait, balance.
Balance.
How do you test the balance?
Just ask patient to close their eyes. Stand up.
No. It may be sensory, it will improve your perceptions. So how do you test the vestibular cochlea? Usually, most of the tests cannot be done in a neurological patients, but if you just suspect this vestibular cochlear nerve alone, the other still can move, limb still can move, you can test is that you can ask the patient to stand up. Can you stand up? Stretch out your hand. Front. Okay, close your eyes. And you march on the same spot. So that if you patient have a one side lesion, the vestibular tissue will rotate to that side, one itself. So this is how to test the vestibular functions. The 9 and 10 nerve combined with assess, because 9 is the efferent, even the gag reflex. 9 is the efferent pathway, 10 nerve is the efferent pathway. So we combine and assess. Right. So you just look at first you have the uvula, whether it's central or not. Then you test the swallowing or phonations. You ask the patient to cough, to swallow water, and then you test the gag reflex. And gag reflex usually, again, because patient usually cause discomfort for the patient, so we don't do in an exam setting. But in the reality, if you have a stroke and all that, it's very important to do gag reflex, right? Because without gag reflex, it can cause an aspiration pneumonia. So we have to put rice tube and all that. So it is important to do that. So to do that, you have to just look at the uvula to see patient whether it is central or not. Okay, so that one I won't do anymore because you all can do that. If you want to be sure, you just look at the mirror and say and look. Okay, then you give a cup, a sip to swallow, right? So swallow and can you cough? So the cough form, right? So this is your 9 and 10 number, and that's about it. And then
uvula is deviated, that is the major issue.
No, this is, you see, the uvula is pulled up by the muscle like that. So if you pull up like that, if this side is weak, it cannot pull. The other side will pull. So it will deviate toward the better side, the good side. The bad side will not be able to lift. Right? So if this side weak, this side cannot lift up, so this side will lift. So that the uvula will deviate to the better side. Right? Okay, this is 9 and 10. The 11 nerve is just a spinal accessory and sternocleidomastoid muscle. So you push my hand to the other side. So you test this muscle. You see your hand contracting here. Because when you push the other side, this is the muscle you are testing the other side. Okay, push. Okay, contracting, push. Okay, can you lift up your shoulder? Okay, resist me. So this is a 11 nerve. It's just these two. Right. Okay. The 12 nerve is a glossopharyngeal, the tongue.
Hypoglossal.
You look at the other fasciculations, any atrophy or not. Can you stick out your tongue in the middle? Okay, it's not deviation. Okay, in your mouth, your tongue come to here. Okay, resist my finger. So you test the power now. Okay, so this is the finish the 12 cranial nerve. So the tongue is your 12 cranial nerve is like your uvula kind of, but uvula is pulling up. The tongue muscle is down there. It will pushing outside. So if this side is weak, the other will push. Then it cannot push. So that it will deviate to the affected side. So if this side is weak, this side cannot push. So this side will push. So that it will deviate to the weaker side. So uvula and your tongue is opposite. Uvula, if deviated to the other side, this is the opposite side is weak. But if the tongue deviates to the left side is weak. So this is the cranial nerve examination. So they will just ask you to do, last time you